Hello everyone, myself Sudipta Roy, Assistant Professor, Department of Pharmacology, Bengal School of Technology, welcome you all to the third and final part of epilepsy and anti-epileptic drugs. In the first part and second part, we have discussed all about epilepsy, its characteristic signs, its types, subtypes, and various electroencephalography recordings of the brain with respect to the different types of seizures. In the second part, we were going through the various types of anti-epileptic drugs, and as you can see in this video, I have divided the anti-epileptic drugs into two segments with the help of green color and blue color. So if you see into it, you will find that we have covered up the green portion in our last video, that is benzodiazepines, barbiturates, hydantoins, succinamides and deoxybarbiturates. Today in this last video, we will be starting with the immunostilbin group and going through the last 5 groups of anti-epileptic drugs. So let us begin with immunostilbin group, that consists of the drugs carbamazepine and oxcarbazepine. In our previous video, we have studied the overall mechanism of actions of anti-epileptic drugs. So here, let us start with carbamazepine. Now, carbamazepine acts very much similar to that of phenytoin. Here, if you can recall the diagram, you see we had the same diagram in case of phenytoin also. What does it do? It exerts its action by prolongation of inactivated state of sodium channels. That is, these drugs affect the membrane excitability by an action on voltage-gated sodium channels, which carry the inward membrane current necessary for the generation of an action potential. Their blocking action shows the property of use dependence. They block the excitation of cells and their firing repetitively. And the higher the frequency of firing, the greater the block is produced. This is similar in case of phenytoin, carbamazepine, as well as the next two classes of drugs, which will comprise of sodium valproate and lamotrigine. All this exerts their action by increasing the prolongation of inactivated state of sodium channels, so that sodium cannot enter the cells and thus the cells do not get depolarized frequently. Another important feature of these drugs are they can block only the higher frequency discharges without interfering the low frequency firing of neurons in the normal state. Carbamazepine is 75% bound to plasma proteins and metabolized in liver and produces an active metabolite as well as inactive metabolites. The active metabolite is produced by oxidation and the metabolite is 10,11-epoxycarbamazepine, whereas the hydroxylation and conjugation reactions gives rise to the inactive metabolites. The plasma half-life initially is 20 to 40 hours but decreases on repeated administration due to autoinduction of metabolism. Carbamazepine is mainly used in complex partial seizures but also used in generalized tonic-clonic seizures, which have 2 phases, and the simple partial seizures. They have some other uses, like in the treatment of neuropathic pain. Now, neuropathic pain is characterized by attacks of high intensity electric shocks, which is set off by the trivial stimulation of certain trigger zones in the mouth or on the face. It is also used in the treatment of mania or maniac depressive illness. There are certain dose-related neurotoxicities of carbamazepine like sedation, dizziness, vertigo, ataxia. Hypersensitivity reactions like rashes, photosensitivity are also common. Hepatotoxicity is rare but may be seen. Water retention and hyponatremia may occur in the elderly because this drug enhances the action of ADH, that is antidiuretic hormone. Carbamazepine is contraindicated with oral contraceptives, lamotrigine, valproate and topiramate because it is an enzyme inducer. The metabolism of carbamazepine is induced by the drugs like phenobarbital, phenytoin, and also vice versa, like phenobarbital and phenytoin will also induce the metabolism of carbamazepine. The next drug of immunostilbene group is oxcarbazepine, which is a newer congener of carbamazepine. It is basically a prodrug and is metabolized in liver to its metabolite called 10-monohydroxymetabolite, which resembles that of carbamazepine and has similar actions. Thus, they also exert their action by prolongation of inactivated state of sodium channels, just like that of carbamazepine. It is converted to its inactive metabolite only by glucuronide conjugation and has less tendency to induce drug metabolizing enzymes. The risk of hyponatremia in elderly is more as compared to that of carbamazepine, and oxcarbazepine is used in case of generalized tonic-clonic seizures as well as partial seizures. So I hope this immunostilbene group of drugs, that is carbamazepine and oxcarbazepine, is clear to you. So let us move on to the next group of drug, that is aliphatic carboxylic acid, which is valproic acid, also called as the sodium valproate. Now, sodium valproate was discovered in the year 1963 in the preclinical studies, and it shows its effect in all types of epilepsies, including the most important absence seizures and infantile spasms. Till now, we have studied about many groups of drugs which are used in the treatment of epilepsy, but we have found that only ethosuximide from the group of succinimides are used in the treatment of absence seizures. So this is the second one where we can find the use in absence seizures. Like carbamazepine, valproate is also used in various psychiatric conditions like bipolar depressive illness and maniacs. Now, if we look into the structure, we will see that valproic acid is a branched chain aliphatic carboxylic acid and exerts its action by 3 different mechanisms. Till now, we have seen that majority of the drugs show their mechanism of action by any one pathway, either by prolonging the inactivation of sodium channels, or by inhibiting the T-type calcium channels, or by blocking the GABA transaminase action. But in this case, valproic acid, they show all these 3 mechanisms. So let us take a look into that. The first one is it prolongs the state of sodium channel inactivation. So just like phenytoin and carbamazepine, this is the third drug we find which prolongs the inactivation of state of sodium channels. The second mechanism is that it inhibits the transient calcium channels, just like ethosuximide. And these T-type calcium channels are responsible for the rhythmic discharges which are associated with absence seizures. Thus, valproic acid shows important therapy in absence seizures which occur in children. The last mechanism is it irreversibly inhibits the enzyme GABA transaminase located within astrocytes, which are neuroglial cells of the central nervous system, and is responsible for inactivating GABA. So the amount of GABA increases, thus the influx of chloride ion increases. So I hope these mechanisms are clear to you. Let us move on to the pharmacokinetics. Valproic acid is 90% bound to plasma proteins and is completely metabolized in liver by oxidation reaction and further by glucuronide conjugation and then excreted in urine. The plasma T-half is 10 to 15 hours, but the anticonvulsant effects are longer lasting. Now, the adverse effect shows teratogenic effect, that is, it causes spina bifida and other neuronal tube defects in the children. Alopecia, curling of hair, weight gain are seen in certain individuals. Anorexia, vomiting, heartburn are common but mild. Monitoring or liver function is advised because it causes asymptomatic rise in serum transaminase. The uses of valproic acid is in generalized tonic-clonic seizures as well as partial seizures. But valproic acid is the most important drug of choice in case of absence seizures. It is also used in myoclonic and atonic seizures and also in the treatment of mania and bipolar illness. With that, I'll move on to the next group of drugs, that is phenyltrazine, and the drug is lamotrigine. So lamotrigine also, as we have discussed till now, acts by prolonging the inactivation state of voltage sensitive neuronal sodium channel, thus resulting in inhibition of high frequency discharges. I hope this mechanism is clear to all of you till now because we have gone through this a number of times. So now it may also block the sensitive sodium channels, thus stabilizing the presynaptic membrane and prevents the release of excitatory neurotransmitters, especially NMDA of glutamate and aspartate. So this is the second mechanism. It is absorbed orally, metabolized in liver by hydroxylation and then glucuronide conjugation. The T-half of lamotrigine is 24 hours but is reduced to around 16 hours in patients who is receiving a therapy of phenytoin or carbamazepine or phenobarbital at the same time. The various side effects at therapeutic doses include sleepiness, dizziness, diplopia, ataxia, vomiting, rashes may be severe reaction, particularly in children, and must be withdrawn if they are seen. Lamotrigine is considered as a broad-spectrum anti-epileptic and are used both in generalized tonic-clonic seizures as well as simple and partial epilepsies. Now, let us come to the last segment of anti-epileptic drugs, that is vigabatrin, topiramate, zonisamide, gabapentin and pregabalin. Apart from these newer drugs, there are many other newer drugs. So if you want to learn them, you may go through them also. Here we will discuss about these 5 drugs. So starting with vigabatrin, the vigabatrin is a vinyl substituted analog of GABA and acts as an inhibitor of GABA transaminase. Thus, the amount of GABA increases and the amount of chloride influx inside the cells increases. It is mainly used in case of refractory epilepsies but has a major side effect of developing visual problems. So that is a limiting factor in the use of vigabatrin. The next newer drug is topiramate. Topiramate has been seen to act by blocking sodium as well as calcium channels, that is the excitatory ion channels, by enhancing the action of GABA, that is enhancing the influx of chloride ions, by blocking the excitatory AMPA receptors, that is glutamate AMPA receptors, the neuronal hyperpolarization through certain potassium channels, and they also inhibit carbonic anhydrase. It has a T-half of 24 hours and is used in generalized tonic-clonic seizures, complex partial as well as simplex partial seizures. They also find use in myoclonic epilepsies. The various ADRs of topiramate include the impairment of attention, sedation, ataxia, word-finding difficulties, and poor memory. Topiramate has been also approved for prophylaxis of migraine but may be used when beta blockers or other prophylactics are contraindicated or are not effective. The next group of drug is called zonisamide. Now zonisamide is also a newer anticonvulsant with weak carbonic anhydrase inhibitory action. How they act? They act by prolongation of sodium channel inactivation. Thus, it suppresses the repetitive neuronal firing, also depresses the transient type calcium currents. The T-half of zonisamide is more than 60 hours. It is also used in refractive type partial seizures, and the adverse drug reaction include dizziness, headache, irritability, metabolic acidosis, and renal stones in some patients. Zonisamide also should be avoided in patients who are sensitive to sulfonamides, and apart from this, no drug interactions have been reported till date. The last is gabapentin and pregabalin. Now gabapentin is a lipophilic analog and thus crosses the brain and enhances the GABA release. The T-half of gabapentin is 6 hours. Both gabapentin as well as pregabalin exerts analgesic effect in neuropathic pain such as in diabetic neuropathy, postherpetic neuralgia, and complex regional pain syndrome CRPS, and various other types of chronic pains. Gabapentin is mostly effective in case of partial seizures. Some side effects include sedation and ataxia. As the plasma half-life of gabapentin is only about 6 hours, it requires dosing 2 to 3 times a day. It is excreted unchanged in the urine and is free of interactions with other drugs. Pregabalin is found to be more potent than gabapentin but otherwise similar. These drugs, as they are excreted unchanged in urine, so must be used with care in patients whose renal functions are impaired. So, with that we come to the end of the discussion on anti-epileptic drugs. This is a table that shows the choice of drugs in case of epilepsy. In the left side we can see the types of seizures are noted down, and in the right side the first one is, the columns indicate the first choice of drugs, the second choice of drugs, and then the alternative or add-on drugs. Like in generalized tonic-clonic or simple partial seizures, we see the first choice of drugs are carbamazepine and phenytoin, followed by the second choice valproate and phenobarbital, followed by lamotrigine, gabapentin, topiramate, primidone, etc. So if we go through this table, we will find that the choice of drugs in epilepsy are well understood. See, in the last one we have status epilepticus. We have discussed about status epilepticus in our second video lecture, and we have seen there that we had the first choice of drug. We had administered the patients with diazepam or lorazepam. Amongst this, the dose of lorazepam was lower than that of diazepam. The second choice was fosphenytoin or phenobarbital. I hope you remembered that fosphenytoin and phenobarbital. Fosphenytoin and phenytoin, there was a difference that fosphenytoin can be given IV, and if phenytoin is given IV, it would develop purple glove syndrome. I hope you remember that. And here the add-on drug is general anesthetic. So I hope you go through this table and you correlate the choice of drugs with the understanding of the videos till date, and that will be helpful to you. Thank you for watching the full trilogy. Let us call it a trilogy because it consists of 3 videos. Trilogy of epilepsy and anti-epileptic drugs. I hope it helps you in better understanding. Thank you all.